Proceeding to general physical examination. On general examination, patient is conscious, cooperative, moderately built and nourished. There is no evidence of pallor, icterus, cyanosis, clubbing, pedal generalized lymphadenopathy. His vitals are stable. Pulse 80 beats per minute, regular rhythm, normal volume and character. Blood pressure 120 by 80 mm of Hg recorded on left arm supine position. Oxygen saturation 96% on room air. Respiratory rate 18 breaths per minute, regular abdominothoracic. Temperature normal, afebrile. Moving on to systemic examination with a focus on higher mental functions. 1. General cognitive profile. Patient is conscious, oriented to time, place, but not oriented to the patient is oriented to the place and person, but not oriented to the time. Patient is right-handed, his attention is intact, and HMSE score is 16 out of 31, with points being lost primarily in the orientation to time, 3 object recall, and copying. These 3 criteria he lost points, so his HMSE came out to be 16 out of 31. Detailed memory domain testing. Immediate memory was intact as evidenced by normal digit forward testing. Working memory was impaired, demonstrated by poor performance on digit backward testing. Recent memory significantly impaired. He is unable to recall what he ate in the breakfast, and he is retaining retaining the 3 objects after registration. Remote memory is also impaired. He is unable to recall year of his marriage. Semantic memory is also impaired. He is unable to recall the basic categorical facts such as color of an elephant. Language assessment. Spontaneous speech. There is reduced fluency with overall decreased word output. There is no paraphasia or circumlocutions. Comprehension, repeating and naming are intact. Reading and writing both are impaired. Coming to frontal lobe assessment, frontal assessment battery score was 6 out of 18. The deficit was significant point loss occurred in lexical fluency, motor series execution, that is Luria sequence testing, and conflicting instructions or go-no-go subtests. Cranial nerves, motor and sensory and cerebellar examination. There was no focal motor weakness, or there is sensory level, or there is cerebellar ataxia or cranial nerve deficit were identified on objective clinical examination. Coming to diagnosis and clinical reasoning. So clinical summaries, here is a 76-year-old right-handed male patient with no known comorbidities presenting with a 2-year history of insidious onset, progressive memory impairment and behavioral or social changes, accompanied by 1 year of urinary and fecal incontinence with no sensory, cerebellar or cranial nerve defects. Anatomical localization is frontal lobe, temporal lobe and their subcortical connections. Pathological process involved is degenerative or vascular process. Etiological differential diagnosis. First etiological differential diagnosis, late onset Alzheimer's disease. It is supported by early, prominent recent memory loss, semantic memory degradation, temporal lobe dysfunction, and an insidious and progressive course of the disease. Second etiology is vascular dementia. It is considered given the progressive decline with an early sphincter involvement and gait changes, though classical vascular risk factors are absent in this case. Next etiology is normal pressure hydrocephalus. It is considered due to the presence of clinical triad of elements like cognitive decline, slowing of the gait, and prominent urinary and fecal incontinence, though cognitive deficits preceded the gait disturbance. Next one is frontotemporal dementia. It is considered due to early behavioral apathy, social withdrawal, decreased word output, and low FAB score, that is 6 out of 18, presenting the behavioral variant or the frontal dysexecutive syndrome.